Welcome to a special episode of Endoscopy Essentials, which is really special. First of all, it's done in cooperation with Orlando Health, and I'm very grateful for this. Secondly, we have a big crowd collected. And thirdly, it's special because it's on a brand new study, randomized trial, led by Orlando Health Digestive Institute. So welcome Ji Bang, Shyam Baradarajulo, Rob Hawes, the endoscopist, big crowd, Pablo Arnoletti, the surgeon, and Takao Itoi, a pioneer in the field. So, and we are spending an exciting time, but we have to start what the study is about. So, Ji, do you want to start and tell?
Yes. So we conducted a randomized trial comparing EUS-guided gastroenterostomy with surgical gastroenterostomy. We enrolled 74 patients in total, and the primary outcome was a combined endpoint of the inability to restart an oral intake, so the gastric outlet obstruction score of 0 or 1, or need for reinterventions, or need for supplemental nutrition, or procedure-related adverse events.
So 3 primary outcomes combined?
That's correct, yes.
And we all hope that the endosonographic version is much better.
That's correct. In our randomized trial, the adverse event rate, the primary endpoint was significantly higher for surgery, so the outcome was worse for surgery compared to EUS.
And could you give some percentages, numbers? So
the difference between surgery and EUS for the primary endpoint, which is a negative outcome, was 31% between EUS and surgery. So the rate was 7% for EUS and 38% for
surgery. Negative outcomes, so vice versa. And endosonography did well in 92, 93%, and surgery in only 60-something percent. Okay, so this is one of the big topics, right? Endoscopy versus surgery, and we are very proud it got to have this paper. Who had the idea, Shyam?
Of initiating this trial.
Yes.
We started doing EUS-guided gastroenterostomy, and then it felt that the outcomes were fairly superior or comparable to surgery. And then we saw more and more patients with increasing frequency. And it became interesting that the surgeons started referring their patients to us for this clinical trial. As we know that clinical practice is important, but it should be based on evidence. So therefore we decided we should conduct the first study, comparing both the treatment modalities and see what it really shows.
Pablo, when you heard this first time, did you feel threatened? Or didn't you like this type of surgery anyway?
No, I think I felt relieved. We've been working together with this group for over 20 years. The patients with malignant gastric outlet obstruction is a challenging population for the surgeon. These interventions are done with a palliative intent, with the hope that the patient will be able to resume oral diet in a short period of time, which is very important for the quality of life of many of those patients. Unfortunately, in the surgical literature and in our own experience, surgical interventions in a dilated stomach that's chronically obstructed with mesenteric retraction, with metastatic disease, with a severely dilated stomach, does not have a good functional outcome. Even when done with minimally invasive procedures, it's not that much the complications, but the patient's inability to resume an oral diet in a timely fashion. And I think that's perhaps one of the main results of this study, is the ability to resume an oral diet in a short period of time for patients who have a large tumor in the pancreas and the root of the mesenteric retraction, sometimes even ascites. Those are patients that are very difficult to treat effectively with an operation.
So the expectation was hopefully there's something which makes a type of surgery which nobody likes anyway obsolete?
I think that's accurate. I know of no surgeon who enjoys doing this type of cases. Again, these are not with a strictly palliative intent. Patients with advanced, often unresectable disease. But perhaps we'll touch on a slight variation. Some of the patients that may not, that end up undergoing surgery, and that where we have to take down this anastomosis, patients who are candidates for curative intent. And these axial stents don't leave a lot of scar. It's fairly easy from the surgical standpoint to remove them, to take them down, and do definitive reconstruction elsewhere. So there's been a significant finding that obviously we weren't know what to expect at the beginning. You know, what is this going to look like if we go back in there and it needs to be removed?
I think that's a very important point, because clinically when you do that or start that, it's not always clear whether this will remain a palliative case forever. That surgery will not be done. And if you do something like that, then you should make sure that you are not in the way of the surgeon in a big way, which, Rob, can be the case if you drain the gallbladder, for example. You know, you also have experience in that.
Yeah, I mean, I think it's a really, really good point. And at the time that a treatment is delivered, the future is not necessarily absolutely clear. And I think we've learned that with the gallbladder. People come in, and at least initially, the initial feeling is that they will never be surgical candidates, and then things change, and they do become. So we have to be careful as endoscopists if we deliver a therapy that we don't, in the long term, take an opportunity away from a patient for maybe a more definitive or better intervention.
I mean, that's one of the big topics for me anyway, what's inoperable. Because if we look at our studies in inoperable patients and then a complication happens and the patient has to be operated, almost nobody dies. So it's a difficult definition.
It's the same as, we oftentimes will have a patient in which we think they have a certain expected life term. The typical example for us was in the plastic stent versus metal stent era. And we used to think, well, we can predict if somebody's going to pass away in 3 months, so let's put in a plastic stent. But we learned from that it's completely achievable.
That's
really
right.
Know how long.
Predictions are difficult.
Yeah, predictions are difficult.
I agree to that. One of my first experience in medicine as a student was I met a patient on the ICU with a blood pressure of 300. And she told me the story that her family physician had told her, you wouldn't live long. You wouldn't live more than 3 months. In the meantime, the doctor had died and she was still out there.
That's silly.
Okay, let's go back for a second to history. Takao, you were there in the very early development. And so what was your initial idea why to do that? Was it just another endoscopic intervention, or was there any special event, special patient you were especially impressed with?
Yes, I'd like to talk about the history of the EUS gastroenterostomy. So 2002, in the European country, there are some this kind of precision and porcelain group and this EUS group. Using, of course, EUS guidance, gastroenterostomy, using not arches, lumen medicine, but special butter, the special butter.
Yeah.
Once, like a tuber puncture, including needle puncture, and so apart from the another distended jejunum, so they comes close to the this lumen and the gastric lumen, and once remove the scope, leaving left guide wire in place, and over the guide wire plus additional button from here and so attach. a very special technique, and impossible mostly the six peaks and one cadaver. So no real human. That's why. But I surprised at that time, 2002. So how nice EUS. That's why. So I'm always thinking at that time. So the 2011, 10 years later, after 2002, the Professor Kembimura published a paper in model EUS gastroenterostomy using randomized methods at first, and then so it was real world system. So I'm thinking of the always reliable or EUS guided procedure. And then, so finally, so we established 2013, the annual model is guided to develop according to gastroenterostomy by so-called the EPAS. So now there are several EUS guided gastroenterostomy procedure using not only EPAS but also the nasogastric tube, nasal tube, pumping to push the water out. But so I'm not sure. Anyway, I'm surprised the GE's paper many years ago. The EUS gastroenterostomy is just surface treatment, like duodenal stent. I thought, but so this wonderful RCT maybe so shows the real world and in near future, not only service therapy, but also the cure treatment. So like you, but amazing. I'm very happy to hear from surgery.
Yes. So it's not only a good idea, you also have to have a good suitable device. So we give credit to Ken Binmüller again here that he developed the stent, which helps a lot.
Historically speaking, around that time, Paul Swain was doing this button, but a little bit afterwards, Greg Ginsberg and his group used magnets. And the problem there was they got a good gastroenterostomy, but then magnets, of course, created necrosis. But then the gastroenterostomy stenosed off very, very, very quickly.
And it took some time.
Yeah.
Okay, let's go back from history to the actual study. When you start such a study, there are several considerations. The first thing is how many cases do we need? That depends on the expected difference. So with a finally 30% difference, you don't need so many cases. What was the initial assumption? What could be? Because that's always tough, right? You screen the literature. I guess the gastroenterostomy literature, the surgical is pretty old, and you have some optimistic series of the new techniques. So Shyam, how did you approach this?
The data was all over the place, but it was quite obvious, like duodenal stenting, which was excellent for short term. EUS gastroenterostomy was also excellent for short term. And then there were several studies that compared the EUS approach to the endoscopic approach of enteral stenting. And what we realized is that the EUS approach is not only good for the short term, but also for the longer term, beyond the 6 or 8 months. Very few of these patients required re-interventions. Then once again, there is this historical cohort of surgical patients were compared with EUS, and there's always a lot of bias in the literature. And our concern was, if we have a very, very large sample size, it would be very difficult because we can see the practice changing and evolving. Surgeons were referring more patients to endoscopy, and we thought it would be difficult for us to randomize patients across the spectrum with a large group. So we went with the best assumption we could make. And that was one of the main reasons why we had multiple outcome measures and created a composite score so that we could be fair. And our sample size panned out to be exactly right. In fact, I think our sample could have been even smaller and we would have still achieved the same endpoint.
A composite endpoint is the other thing which can be problematic. I think these composite endpoints are more or less close to each other and they are clinically relevant, right?
Great.
So G, when you go, you can also secondarily analyze the 3 subgroups of the composite endpoint. Were there also significant differences? It's not something you should embark on if you don't plan it prospectively, but still ex post.
Yeah, so we did an individual comparison of the components of the composite endpoint, and EUS is superior for restarting oral intake, so time oral intake, the time to starting liquid diet and solid diet, the proportion of patients who are able to go home on a solid diet as opposed to liquid diet. And we also compared other secondary endpoints such as quality of life and COGS, which I think is a really important factor when comparing two vastly different treatment modalities, medicine versus surgery, essentially.
So superior in all points, total victory. What if somebody says that's too good to be true? But that mirrors reality, right? And it's shown by the fact that surgeons don't want to do it anymore.
I mean, we were quite surprised that we thought the adverse events in surgery could be higher, but that was not true. The surgical adverse event rate was comparable to endoscopic outcomes. But the fact of the matter is the surgical literature tells us that when you do a surgical gastroenterostomy, there is a delay in gastric emptying. So naturally, those patients took a longer time to tolerate diet. These are patients with terminal disease. They are in the hospital for a longer period of time, and they've got more comorbidity. What was very interesting in the trial was that although it did not pan out significant after adjustments for multiple co-founders, patients who received an EUS guided treatment were able to receive chemotherapy much earlier than the surgical cohort. And this is very important in a difficult subgroup of patients with a limited life expectancy, that we are able to treat them minimally invasive. We are having a shorter hospitalization. The costs of the treatment are less. They are able to go home, start chemotherapy. And therefore, I think if you look at the whole spectrum, it's a win-win situation.
What I also found interesting, and what was maybe incorrectly, I'm not sure, criticized by the reviewers, that there was no uniform surgery. Because I think in more than 50%, you could not either primarily do or go on with the laparoscopic approach. So it's not a laparoscopic versus endoscopic, it's a surgical versus endoscopic. And you had to do some kind of upstaging or upscaling of the surgery. Maybe, Pablo, you could comment on that.
Yes, and that's a valid concern, and if you wish, a limitation of the study. Now, this is not a homogeneous population. Many of these patients have advanced malignant disease, like we stated, with large tumors in the pancreatic head or the mesentery, with metastatic disease, with peritoneal implants. And the laparoscopic or minimally invasive approach may not always be feasible. But across all the different subsets of patients in the surgery, I think the endoscopic procedure still showed an advantage. And I wanted to illustrate two other points, perhaps. One is what Shyam was saying, that one of the main quality measures as a surgical oncologist is the time to implementation of the kinetic treatment, which is often delayed because of the need for the patient to be able to resume an oral diet, an enteral diet. And the chemotherapy, chemoradiation, even with the palliative intent, cannot be implemented oftentimes until the patient is able to eat. So this is an important quality measure in the oncology area, that patients are able to start systemic treatment soon. The other one is that of collaboration, and as Rob was pointing out, and from the gallbladder patients as well. Well, we have a close direct communication. Patients who are never surgery candidates, versus patients who may have surgery, may even have surgery with curative intent. And that's an important discussion, not to make assumptions that we think that the patient will never have surgery, but perhaps they will. And that's something to discuss up front. And I think it also gives patients and their families peace of mind that a team evaluates them from different perspectives, and then it recommends a course of action based on this. analysis.
Good point. I think when you do a randomized study, you have your inclusion criteria. So if you say it has to be laparoscopic, then that's a subgroup. And I mean, I'm biased, but I prefer this approach that you say it's surgery, and I try to consider laparoscopic surgery, but if not, then I upscale it to open surgery. So I think and I guess you had to exclude less patients, right, Sean? Yeah, yes, that's right. So I think we turn this limitation into a positive point. At least we try to. Well, maybe finally something technical. We had a separate podcast series on this. You have to fill the duodenum or the upper jejunum with water. That's mostly possible with a nasobiliary or nasogastric tube or whatever. So, but Takao, you have developed a method which you either could use primarily, or if you don't get a good target window, right? So would you like to briefly explain?
Yes. In order to get a reliable procedure for gastroenterostomy, so I invented a special double balloon in order to occlude jejunum or duodenum completely occluded.
So the segment where you want to put the stent in, a balloon before and after. Yeah.
And the anatomically, and the ligament of beyond, ligament of thorax, the most closest to the stomach. That's why. So, if we can occlude between the ligament of thorax to balloon, maybe a most closest position to puncture. That's why so we invent a double balloon. The length of double balloon is 20 cm. 20 centimeter, it's enough to occlude as a targeted area. And once we advance double balloon tube and occluded jejunum and duodenum, it's maybe 100 to 150 cc serum is enough to occlude distend to jejunum. If so, like pseudocyst or gallbladder, descended gallbladder through the gastric wall, the EUS can depict easily only descending jejunum. It's a really target for the gastroenterostomy. Yeah.
So would you recommend to use it primarily or only in difficult cases?
It's a good question. I think maybe good for the beginner. Good for the beginner. Mm-hmm. For the beginner, if we use double barreling, so it's enough time to depict the descended jejunum. So, for example, it takes 3 minutes or 5 minutes, it's still there, no flowing. Yeah, still there, the distended jejunum. So it's good for the beginner, but for the expertise of EUS, I don't think so. Just another biliary tube and water pumping, and quick insertion. The using axials is impossible. But even for expertise, difficulties like that. So yes, this case also not so normal anatomy. Sometimes the cancer patient looping and back to the right side, the jejunum, and at that time, sometimes very difficult to find appropriate position to puncture at that time. Using double barrel, and so take a time, but so easily depict.
Yeah, the end of it was pretty easy. So we agree it's surely recommendable for difficult cases, which includes almost all cases for beginners. And that's also what would be a period. Well, at the end of this very nice discussion, there's one person to summarize. I think the study is a game changer and it will influence guidelines. Robert, I think your team can be proud.
Well, I think so. Man, I think so. I must say, I'm impressed with the results of gastroenterostomy, and I think it goes back to what Shyam was saying. It's the rapidity or the quickness that these patients can eat, you know, we share patients who have undergone gastroenterostomy and surgical gastroenterostomy, and many of them require some enteral tubes for some time before the stomach rebounds and so forth. So I think for the reasons that were mentioned earlier by Pablo, it's the rapidity or the rapidness in which they can eat, which then allows them to get a definitive therapy, and they have a limited lifespan. So I think very much it's a game changer.
Absolutely. So thank you, guys. This was a brilliant discussion. Thank you very much. Thank you very much for viewing, and see you next week.